Hello everyone, my name is Ali Hassan. Today I'm going to present the third part of mandible fracture. The intraoral approach is the usual access for a simple fracture of the body, symphysis and angular region, advantage of avoiding facial scarring and risk of injury to the facial nerve, but the major disadvantage is limited access, vestibular incision. Now I will open simple video. First step, the incision market, then local anesthesia and filtration, and incision, reflection of the mucoperiosteal flap, and fracture exposed. The mucosal incision, unless contraindicated, infiltrate the area with the local anesthetic containing vasoconstrictor. Make an incision through the mucosa in vestibule between the canines. The incision is made between 10 to the 15 mm away from the attached gingiva posterior to the canine. The incision is only 5 mm away from attached gingiva, staying superior to the mental nerve. In this figure down, we can see the surgical flap dissection and Mentalese muscle. Minimally invasive endoscopic repair condylar fracture offers less morbidity and operating time, as well as quick patient recovery. Fixation method in open reduction internal fixation, transosis wiring and Kirschner wire, K-wire, and mini pallets and Laxacro. Complication: ankylosis of a TMG. Ankylosis can be fibrous or bony. Predisposing factors include A. Age. The major incidence is below the age of 10 years. B. Type of injury: intracapsular trauma with the crushing of condyle. C. Damage to the disc. Disruption of disc is likely to occur in two particular types of fracture: a severe intracapsular compression injury or fracture dislocation. Other factors is the site of a type fracture and the age of the patient at the time of injury, the duration of IMF, the extent of damage to the disc. Other complication: malocclusion, limitation of range of movement, displacement of the disc, chronic pain associated with dysfunctional movement or with osteoarthritis, disturbance of growth in the children. Coronoid process fracture. Fracture of the coronoid process are relatively uncommon. It is generally accepted that they account for approximately 1% of all mandible fracture. The coronoid process is infrequently fractured because it's protected by zygomatic arch. A diagnosed coronoid fracture is indication for the surgeon to look for an associated zygomatic arch fracture. Coronoid process fracture. Coronoid fracture are often incidental finding on the X-ray when looking for associated maxillofacial injuries. Diagnosis of coronoid process fracture would most likely be made on panoramic X-ray or CT scan, most commonly. There are other associated fracture. Isolated fracture of coronoid process are extremely rare. CT scan provide the best delineation of coronoid fracture morphology. This CT scan demonstrates fracture of the left coronoid process, not associated fracture of the mandible body region in this figure. The indication: very rarely does a fracture of coronoid process require treatment. Most fractures are simply observed. Some surgeons would advocate removal of coronoid process in case of the persistent mouth opening restriction. In case of the surgically treated comminuted ramus fracture, and associated coronoid fracture may be reduced and fixed. Special consideration: edentulous mandible fracture and pediatric fracture. Pediatric fracture, green stick fracture is more likely to occur. Fracture in young children heal very rapidly. Treatment is generally of a conservative nature. Mandibular fracture may disturb the growth of the mandible when fixation is needed. In very young with unerupted, a splint for the lower jaw alone may be used. When sufficient firm erupted deciduous and permanent teeth are present, eyelet wire or arch bars can be used. When there is sufficient displacement or fragments, open reduction internal fixation may be necessary. Slight imperfection in reduction can be accepted. Edentulous mandible fracture. Special challenge in treating this fracture. Alveolar resorption is 4 times greater in mandible than maxilla. Inferior alveolar vascular supply to the bone is greatly compromised. Too little cancellous bone for repair. Osteoblastic odontocele. Normal healing potential is retarded. Open reduction amount to stripping of portium, which impair osteogenesis, as there is a greater dependence on posterior supply in atrophic mandible. Treatment: undisplaced fracture require no active treatment. Close reduction. Gunning type splints denture wearer. The denture can be modified to allow IMF. Severely atrophic edentulous ridge fracture. Open reduction with the primary bone grafting. When an open reduction internal fixation is required, reduction should be made with minimum exposure of a fracture site to minimize interference with periosteal blood supply.